Hello, everyone. Welcome to August 2021's Data to Drive Decision Making. My name is Kristen Paulson. I'm the Chief Operating Officer here at CIVHC. Today, we're going to be reviewing Medicare reference-based pricing data and talking about some of the reports that are providing support to the employer healthcare purchasing alliances here in Colorado. Just some housekeeping. All lines are muted. Please enter your questions into the chat box. This webinar is also being recorded, and a link to the recording will be posted afterwards in the resources page on civhc.org. Additionally, we hope to have a few minutes to answer questions at the end of the presentation, again, using the chat box. So let's get started. Your other presenters today are going to be Miga Jha, Dave Dale, and Emma Anderson, some of our awesome employees here at CIVHC that are doing this incredible work. And here's today's agenda. We're going to talk a little bit about CIVHC and the Colorado APCD before reviewing Medicare reference-based pricing, and then talking about the data available to support employer cost savings efforts. So the Center for Improving Value in Healthcare, or CIVHC, is a nonprofit, nonpartisan, independent organization with a mission to empower individuals, communities, and organizations through collaborative support services and healthcare information in advancing the triple aim of better health, better care, and lower costs. We focus our service on healthcare change agents, or individuals, communities, and organizations who are working to lower costs, improve care, and make Colorado all around healthier. These change agents span the entire healthcare system, from providers, payers, and facilities to researchers, policymakers, and consumers. We inform those change agents with both public and non-public releases of Colorado All-Payer Claims Database data. Public releases of the data are available to the general public at civhc.org. And finally, a brief snapshot of what's in the Colorado All-Payer Claims Database. This and more information about what the database contains is available on the website under the Insights dashboard. As you can see, we are closing in on a total of 1 billion Medicare, medical, pharmacy, and dental claims from over 44 different public and private payers. Those claims represent almost 8 million people over the years of 2013 through 2020. All right, so I will be walking through the background of the Medicare reference-based price report before handing it over to Miga to demonstrate the public report. For several years, CIVHC has been collaborating with the RAND Corporation to create Medicare equivalents of commercial claims in order to gain an idea of both the differences between commercial and Medicare payments, but also to benchmark Colorado commercial rates to other states using a common measure or metric across states. The CIVHC report that we're going to be looking at later features information about the Division of Insurance and county level Medicare reference-based pricing costs by mapping, and then also looks at the patient experience using the CMS 5-star rating so that we can get an idea of both cost and quality in one snapshot. It also includes trend information from 2017 to 2018 so we can see how things are moving, and then infographics both at the DOI and the hospital level. Some of the key findings from this year's most recent information is that our outpatient service payments are significantly higher than the national average. National average is about 267% of Medicare, so just over 200% of Medicare. And in Colorado, it's over 300% of Medicare for our outpatient services. This really pinpoints outpatient services as one of the biggest cost drivers for healthcare services in the state and places Colorado outpatient services in the most expensive on average across the country. We also found that hospital prices are varying widely across geographies. 2 of the lowest paid hospitals and 2 of the highest paid hospitals are all located in rural counties. So we're seeing less similarity within rural or urban areas. From 2017 to 2018, the payments in all but one region of the 9 DOI regions in Colorado decreased. Nationally, however, only 2 of those regions are still underneath the national average or the national benchmark, meaning that Colorado overall is still one of the most expensive places in the country to be receiving care. Of the 52 hospitals that had both 2017 to 2018 data available for trend measuring, the majority had a reduction in commercial payments in 2018 compared to 2017. But we did have 11 hospitals that increased their rates over 2017 rates. Here you can take a look at the variation across hospitals in Colorado. They vary from 124% of Medicare to over 500% of Medicare on average. And you can see the distribution here. This is obviously too small to be able to read in detail, but this is available on the website. You can see right here this blue line. The first blue line is the national average. And then the second blue line, the lower blue line, is the Colorado average. And so you'll note that the majority of the hospitals in Colorado are above that national reimbursement average. And here we can see the trends from the Division of Insurance, looking at the variation from year over year, and then also looking at current distribution. So you'll notice that the West region went up by 2.5% from 2017 to 2018, and that the vast majority of our DOI regions are significantly above the national average of 247% reimbursement. So how are employers using reference-based data? So this is a common metric, as I mentioned, across states. So we have a lot of examples from other states about how these can be used to really improve benefits and improve contracting for employers. So the California Public Employees Retirement System used the reference-based information to set a benefit threshold level of $30,000 and saved almost $3 million in just their first year. Montana is using reference-based pricing to set their contracts and to set their payment limits so that they have a maximum of 230% of Medicare as a hospital payment. And then this can also be used for reference-based pricing, not just an overall contract, so that individual vendors could contract with individual employers, can contract with a vendor to reprice claims and pay a set percent of Medicare across the board. So I'm now going to switch over to the live report and let Migo walk you through how that report works and what's available on our website. Migo?
Good afternoon, everyone. Thank you, Kristen, for the introduction. So this is an interactive dashboard, like Kristen mentioned, and it is on our website. So you can go to civic.org and look for this. So we have 2 tabs here where we are showing overview data and then the trends data between 2017 and 18. In the overview tab, you can see there are 3 sections. The first one is showing the filters, which you can select by which region you want to see, like county or DOI. You can select DOI and the map would change on itself and it would make interactive as well. Second is the service type, like it was mentioned, we have 3 different service types: inpatient services, outpatient services, and combined inpatient and outpatient. And the third portion is showing the reference of low to high in the color coding. In the map region, it is interactive. If you can hover over it, you would see a tooltip where you can see which DOI or county it is and what percentage changes are there. You select any one of the county, and the portion of the third portion of the analysis below changes itself. The hospital names changes which are available in the RAND data for that county or DOI region you have selected. Once you select over the map again, it will revert back to the home dashboard. And the third portion on the down is the analysis of all the hospitals in Colorado. We are showing 3 different numbering. Can you cancel it? Yeah, thank you, Kristen. If you go down, yes, you can see there is analysis. We have mentioned 5 or 6 different parameters for each hospital based on percentages of Medicare by hospital, by DOI, and by county. We have also included patient experience and hospital overall rating from the CMS data. On here, you can select each of the hospital and it would show in map which DOI region is the hospital representing. And if you click back again on the hospital name, it would revert back the map. Click on the region again, Kristen. Thank you. The second tab, which we have, it's about the trend since RAND is producing these results for last few years, and we are showing results based on 2017 and 18. Not all hospitals are available in both the data. That's why you would see many hospitals with null data. And that's why the trend analysis won't show any data accordingly. Here also we have two sections. First one is the filter where we are letting people choose between DOI and county. Second one is within DOI or county, which region do you want to select? Third is the service type like the previous dashboard. And last is if you want to see the ascending and descending order of any one of the columns, you can select that and it would change automatically. And you might see like in 2017, one hospital has highest percentages, but it may not be in 2018. And you can select even the percentage change and see which hospital is faring well between these two data points. So if you have any questions, reach out to me. And this is as interactive as you can. Select, you can, this is right now selected based on alphabetical order by hospital name, but by sort by, you can change it whichever descending order you want to see them as. Any questions, please let me know.
Thank you, Miga. And we'll be answering questions in the chat box. And if you have any more detailed questions, you can feel free to reach out to Miga here at Civic. I'm now going to hand the presentation over to Dave Dale and Emma Anderson. We're going to walk through some of the reports that we have available to support employers in their work for better prices and stronger negotiating. Dave?
Hello, everyone. My name is David Dale. And if you could go to the next slide, Kristen. Civic began to work with the leadership from the Colorado Business Group on Health and the Peak Health Alliance leadership and others, employers in particular, to develop several standard reports to help inform the employer community around improving quality and lowering costs. To date, we have 7 reports that have been developed, one of which is the reference-based price report, which Miga just provided a brief overview to. Additionally, there's the low value care, potentially avoidable ED visits, and top 5 procedure cost savings. Emma is going to walk through 4 of these in a moment, the bottom 4, and we'll give a snapshot of what those reports look like. But it was a very collaborative effort working with the leadership of the purchasing alliances and employers to, over the past several years, to develop the framework for these reports. Next slide. At the present time, all of these reports are available at no cost to employers or employer groups who have sufficient claims volume in the Colorado APCD. We are able to provide reports. We do follow the CMS data suppression policy. So for smaller groups where the claims volume and the counts begin to appear where they are actually less than 11, we are not able to produce reports with claims volumes at that level. But where there is sufficient claims volume for employers or employer groups, we are able to develop these reports, again, at no cost. We are providing them and very much encouraging and asking for feedback on how these reports are useful. What could we do to improve upon them? And if you do have an interest in exploring whether we're able to provide a report for your group, you can reach out to me. My email address is here. The process is pretty straightforward. We can turn them around quite quickly. We will do a demo of the reports for you and again, set up a feedback loop call because we're very much interested in identifying every opportunity we can to make these actionable and user-friendly for the employers. Next slide. Before we get into the demo, I would like to also share an example of the other analytic capabilities that exist at CIVHC. This was a report that was requested by the Colorado Purchasing Alliance, one of the purchasing alliances, and it was a case study looking at potential cost savings available for outpatient procedures, comparing the cost of those services at hospital-based facilities versus independent freestanding centers that were not owned by a hospital or a health system. That was the ask for this particular report. And we looked at this across 10 outpatient surgical procedure categories for 2018 and 2019. You can see those categories in the orange boxes, and then the average savings for those services being performed at a hospital-based outpatient center versus an independent freestanding center. The average savings across the 10 categories was 44%. In the bottom of the screen, we do show a potential cost savings for this time period. And on the left-hand side, you see there, if there was a shift of 10% of the volume for this population that we looked at from the one setting to the freestanding independent setting, a 10% shift in volume would result in a $1 million savings, whereas a 50% shift would result in a $5.7 million savings based on the analysis that we did. So this is an example of the type of analytics that we at CIVHC are able to do with working with data requesters. And what I'm going to do now is hand this off to Emma and have her give you an overview of 4 of the actual employer reports that we have developed. Emma?
Thanks, Dave. Hi, everyone. I'm Emma Anderson. I'm a reporting analyst at CIVHC that's been working on these reports for the last year and a half, almost 2 years. I will say, unfortunately, we don't have time during this webinar to go into the live reports, but there's a lot of interactivity built into each one, the ability for the user to drill down and see exactly what they want to see in this data. So if you're at all interested, I really do encourage you to reach out so we can set up some demos and you can see these reports in action, because you can get a lot more insights than the high level points that I'm just going to point out today. The other thing I want you to know about all of these reports, with the exception of the prescription drug report, is you get to see your data and compare it to a county of your choosing, a division of insurance region of your choosing, and statewide benchmarks, the same way that the reference-based price report that you just saw did. So this first report is the top 5 procedures cost-saving analysis. So we're actually able to identify the entire cost of a procedural episode. And what that means is we're looking at costs from before the procedure, such as possibly diagnostic imaging, any labs that need to be run before the procedure, the cost of the procedure itself, and any aftercare or post-procedure services that occur. So rehab, physical therapy, medications, as well as any complications that occur during the episode. So by being able to group all these costs, we're able to see what something like a knee replacement looks like from the very beginning of the process through all the aftercare and post-procedure. It's a much more accurate reflection of what that knee revision is actually costing than just looking at what that procedure costs. So with this report, you can identify amongst your employee population what are the types of procedures that are driving the high costs. You can examine the costs by each of those phases that I've been talking about, the procedure itself and post-procedure, and see how those costs are varying based on the setting, whether it's inpatient, outpatient, professional. You can compare the average costs of post-procedure services. So we broke down that post-procedure phase into the different physical therapy, medication, rehab, even ER visits and complications, and on average, what is being spent on each of those. As I've mentioned, you can see the complication rates at both the procedure phase and post-procedure phase. And then the final portion of this report does compare for each type of procedure, what is being cost on average when a member goes to a specific facility. So then you get to kind of cost compare between different facilities your population is going to. Cost here would be total charges. So it's not just what the patient is incurring. It's also what the providers are covering as well. I will say the facility comparison, while very useful, that is subject to a lot of suppression. As Dave mentioned, anywhere where less than 11 procedures have been performed, we do have to suppress. But we hope as we add more and more years to this data, that becomes less of an issue. Next slide. Okay, our chronic conditions and avoidable complications report. So we are able to look at members that have these chronic conditions and identify of those members, how many just have one condition and how many are suffering from comorbidities. So perhaps they have 2 or 3 or more conditions, somebody who has diabetes, as well as hypertension. So by breaking down your population this way, you're able to identify not only what chronic conditions are driving high costs among your population, but also the specific member population in terms of comorbidities, how that is driving cost and those differences between those member populations. Then you can also see, based on the type of chronic condition and that comorbidity population, the complication rates in ER rates and costs associated with those. And then we break it down even further so that you can see, based on the chronic condition, what are the top services that those members are incurring. And when they do need to go to the ER, what are those top diagnoses that are driving them to the ER and thus a lot of those high costs. And then again, I'll reiterate, as you can see on the screenshot here, you always get to compare your own data to counties, DOI region, and statewide. So you can really see where your data or your population is very different from some of these geographic benchmarks. Next slide, please. Okay, prescription drugs and generic alternatives. So this is broken down into 3 different dashboards. The first one you're seeing here, a very high level overview. What are you spending on pharmaceuticals and how does that break down for specialty drugs versus brand versus generic drugs? The rest of the report will show you amongst your employee population, the top 25 drugs that were prescribed, both in terms of spending and in terms of volume. And then of those top drugs amongst your population, which ones have generic alternatives? And it will give you the details, name and dosage, strength, all those details of what those generic alternatives would be. And that's really where the cost savings is going to be. Where can you possibly swap out a higher cost drug for a generic alternative? So this report is probably one of the most, probably one of the most immediately action-oriented and useful in terms of what you can use to lower some of these pharmaceutical costs. Okay, next one. And our cost driver analysis. This report is, I think, the best for just giving you an overall picture of what your healthcare spending looks like amongst your employee population. So at a very high level, you can see of all your costs, what percentage was incurred by inpatient services, outpatient, professional, or pharmaceutical spending. So you can see that breakdown and you can see how that changes over time. And we try to give you both total spending and per member per month spending. So you're not comparing apples to oranges. And then on the second half of this report, you can drill down into one type of spending category, let's say outpatient, and it will give you a list of all the most expensive services within that spending category. So for outpatient example, you can see how much you're spending on surgery, how much you're spending on ER rates. And then you can really drill down to the types of services that are driving costs within these spending categories. Next slide.
Thank you,
Okay,
Emma.
so that's all I have. I know it was very quick. I just encourage you guys to reach out. We are also very happy to do demos and discuss these in more details. There was even more reports we've developed that we didn't have time to show today. So if there's any interest, please contact us, please contact Dave. No wrong door. We're very happy to talk with you guys.
Great. Thank you so much, Emma. I'm now going to introduce Robert Smith, who is the CEO of the Colorado Purchasing Alliance, and Claire Brockbank, who is the CEO of Peak Health Alliance. And these are two of the employer alliances that have used some of these reports, so they can talk a little bit about their utility and what this means for the work that they're doing. Bob, I know you have got a few slides, so I think I might hand it over to you first if you want to talk through those slides.
All right, very good. Thanks very much, Kristen. And Emma, I really appreciated what you presented. It's one of the reasons, and I've said this many times, that Colorado is the best positioned state in the country to drive state-based reform, which is where it's going to have to happen. And I think CIVHC, particularly with as a robust database as you have with the all-payer claims database, it benefits us in a number of ways. And we've long considered CIVHC to be a strategic partner, sharing data with our employers, and we've used that in a number of ways. But now we're actually beginning to use CIVHC as a critical resource for the Colorado Purchasing Alliance. And so if you flip to the next slide, and I just have just a couple. So I think I genuinely believe one of the reasons that the Purchaser Business Group on Health out of California, which buys healthcare for about 40 plus jumbo employers across the country, one of the reasons they wanted to pilot this local national alliance with us is because of the robustness of the data that we have. So this is who we're working with. We represent, you can see the employers on the Colorado-based employers, but it's difficult to move the needle with just Colorado-based employers, and many of our employers are national employers. So you can see that by being joined by the Purchaser Business Group on Health, we roughly doubled the size of the purchasing. So if you flip to the next one here, I'll show you how we use these data. So this is basically a summary of the sources and uses of data. I'd point out the quote by Deming. I think it's an important point. We really basically have three strategies: identify and select, collectively identify and select high-performing, high-value providers, and that's key. That's what we're doing with PBGH. We're also engaging physician-directed entities both at the statewide level, Colorado Medical Society, and others, because we want to put physicians in control. And we've committed to physicians that the data that we look at, we will share with them to gain their trust. And then the third is to engage and empower employees. The RAND relationship, which Dave touched on, is absolutely critical to this because we do have one of the most robust all-payer claims databases in the country. By having that collaborative relationship, and it's always gone very smoothly, we can use RAND data as well as embedded healthcare Blue Book data to drive all three of those strategies. And that's why the APCD is so central. We'll also use it, as you can see, to run reports on low value care. That's been very helpful to us. The outpatient pricing analysis has been very helpful to us, and then a number of employer supports. We use some other data from MedPAC and Healthcare Regional Information System to do benchmarking, but that gives you a sense of how central the all-payer claims database is to our efforts.
Great, thank you, Bob. I'm going to pause the share real quick and ask Claire Brockbank if she could give a few words about the work that you're doing with the Peak Health Alliance.
Thank you, Kristen. And thank you for having me. And I do want to stress that Emma ended her presentation with an offer to assist. And I will tell you from personal experience that the offer is very real and genuine. The team at Civic have been amazing in terms of, helping wrap their brain around the issues that we deal with. So I would really encourage you to call Dave, to call Emma, to reach out, because they really are fantastic. It's a resource that we are extraordinarily lucky to have, in addition to the data, of course. But I think, as Bob said earlier, you want data to turn into action, and it takes the guidance sometimes of some good data navigators to help you turn it into action. So I thank you all for that work and encourage people to take advantage of that. So the team asked me to tell you a little bit about how Peak uses data, but I thought it might be helpful to just give a very brief description of what Peak Health Alliance is. And we are Colorado's only licensed and fully operational healthcare purchasing cooperative. That gives us the ability to negotiate directly with both providers and carriers to lower health insurance costs on behalf of our members. We pool large self-funded employers, small employers, and individuals to speak with one voice. So we currently operate in 7 counties. We'll add an additional county in 2022. And between 2020 and 2021, we estimate we have saved about $9 million in lower insurance premium costs directly for our communities. And those are, that is separate from reinsurance. So we are up and operational and walking the talk with all of the challenges that goes with that. So how do we use the data? I would say it's our starting point. So in new communities, so if we started in Summit, then we expanded to 6 communities, we've expanded to another community. We use the APCD data to help analyze what's actually driving the cost of care in our communities. And that can be different in a rural community served by a critical access hospital than in Denver, or a mountain resort community served by a large health system. So that becomes really an important part of our analysis. That data helps us level the playing field when we talk with providers. And I will say, you've heard this morning, or this afternoon, I guess, that there is the publicly available reports, and our first stop in the process is the publicly available reference-based pricing report. As Bob talked about, that's done in combination with the RAND data. The second piece, though, is the custom data analysis, and we have in all of our counties taken advantage of the opportunity to get custom data to dive a little bit deeper into understanding in greater detail where care is being provided, what might be driving the higher prices, what are some opportunities, et cetera. So that data really levels the playing field for us. When you sit down with a hospital and they say, no, our costs are actually very, very reasonable, and you're able to say, well, we're not sure that 850% of Medicare is reasonable, it changes the dynamic of the conversation. It allows us to find a constructive middle ground, and it allows us to have a baseline. So when we know what the percent of Medicare is, as an example, in Summit County or in La Plata County, Durango, and then we get a fee schedule from providers, we are able to then run that through with our actuary and know how much movement we've had from the baseline percent of Medicare. So hopefully that makes sense to the folks in your audience. It gives you a sense of change, and you can validate. And healthcare is a black box. Anytime you can use data to validate what you're doing, you have more odds of success. I think that's why our negotiated fee schedules have resulted in such dramatically lower premiums, because we were able to make sure that those fee schedules were real, right? I think the second point I'd like to make is that although we often look to immediately reduce the cost of insurance to our members because that's such a pain point, but we know that addressing those other cost drivers is equally important in the long run. And that's where the employer reports that the team described, that Emma just finished describing, are so important. Those help us think about what are our opportunities to identify unnecessary care. Do we have a generic versus name brand prescribing issue? Are we seeing underutilization? For us, then we have to take that and work with our two very distinct members. I see a question that just came up and you must have been reading my mind. We serve self-funded members, insured group members, and individuals, folks on the individual market. So that is very unique nationally. So when we use that data, our self-funded employers use it similarly to how Bob's employers might think about using it. They have to think, help them think about benefit design. We help them think about other ways to structure the way they are choosing to offer services to their employees. For our group and our individual market, we have to work with the insurance carriers that we've partnered with. And part of the condition of partnering with Peak is a willingness to sit down with that data and identify opportunities. So as an example, we knew that mental health was a big issue. We knew from some of the CIVHC data what a high percentage of our ER care had a mental health component to it. And so we used that data when we negotiated with and selected our first carrier to say, we want to change the benefit design for mental health. We want to remove the deductibles for mental health. We want to remove the copays for mental health. So in our counties right now, our carrier on the insured side, not the self-funded side, is required to pay, to provide outpatient therapy with no copay and no deductible. That was driven by data. Now, we have not been able to test the impact of that in part because of COVID, but we will be knocking on your doors as our, as the data comes through. So those are a few snapshots of how we use the data. I think what's really important though, if we have people on the webinar who are thinking about doing this, is to remember that as Bob, I think of it as Bob's outpatient procedure report. I know it's a case study that you guys featured, but the APCD data lets you get your arms around what the opportunity is. It doesn't tell you how to take advantage of it. It doesn't tell you how to realize the savings. And so that's where it's really important to know that the work, that it's hard work to get to the report that helps you diagnose the savings, but you've got a lot more work to then say, how do we actually realize it? And then how do we measure it on the back end? And we're not at that measuring on the back end yet. We've been operational for 2 or 3 years, but we're not there yet. But I anticipate a pretty robust partnership with CIVHC as we do get there. I'll pause there. That was a lot that I just threw out.
Great. Thank you, Claire. And thank you, Bob, too. We do have a few minutes for questions. I'm going to give everybody a couple minutes to get something in the chat box and think through what you've just seen, what has just been demoed, and then what Bob and Claire have had a chance to talk about. As folks are doing that, a question for two of you. These purchasing alliances are relatively new entities. It's a relatively new approach to tackling the costs of employer-based care. Can you talk about a little bit about sort of what your ultimate, what's the dream? Where does this go in the future? What's the dream? And then what are some of the biggest obstacles you have to getting to that endpoint where you really think that this is going to, what does this become down the road?
Bob, I'll let you go first.
Well, yeah, purchasing alliances are new in Colorado. They've really been around for a long time. And when I was with a health system in Savannah back in the early 90s, we negotiated with the Savannah Business Group. Purchaser Business Group's been around for quite a while. There have probably been 15 or 20 of these that have popped up, and then actually many of them have gone away over the years. A few have still remain. There's really a marvelous catalyst for payment reform. If you were to go to their website, there is it's a review of the last 10 years of group purchasing alliances. And if you were to go to their website, you can see what makes these things successful and what makes the ones that have failed fail. But I would say if there's a critical variable that I observed up in Summit County and that I've observed in other coalitions, it's the resolve and the courage of the employers. You can create the infrastructure, But that just creates the opportunity for these to be successful. It doesn't make them successful.
I would agree with what Bob is saying, and Peak was pretty proud to be featured as a successful purchasing alliance in that Catalyst for Payment Reform report. But we talk a lot about the critical success factor is intestinal fortitude, right? It's the translation of you get the data and the information, but actually making a change is difficult. One of the reasons that Peak includes small employers and individual employers is that, frankly, we find that those folks are much more cost sensitive and willing to walk with their feet. They are less risk averse. And so they are more willing to reward the hospital, the provider, the carrier that is willing to come to the table, perhaps not happily come to the table, but is willing to actually step forward and provide more transparency, more accountability, more value-based benefit design that actually does things like provides mental health, with no deductibles and copays. That those folks walk the talk sooner than self-funded employers, and the self-funded employers come in later, and we're seeing that in Summit County. I would say the ultimate success, Kristen, is having a system that is more rational and more transparent, that allows a community, however you define that community, a little Summit County, a whole Region 9, the whole state, to have a more rational and objective way of paying for and delivering healthcare. And paying, I don't mean just can you get a lower price, but are you paying for the right services at the right time, et cetera. The barrier to that is that the system as it's currently structured is very profitable. It's profitable for the hospitals, it's profitable for the providers, it's profitable for the insurance carriers. And until the employers and the individuals actually feel that pain and decide that you can change it, it is difficult to make change happen. We find, I will give a shout out to Centura Health, because while they have evolved into an incredibly good partner, they have stepped forward. Is there room for improvement? Yes, absolutely. But they have stepped forward. But many hospitals have been very, very reluctant to do that. I think the other thing that's super important that gets overlooked in thinking about the success of a purchasing alliance, if you deal with insured carriers or with third-party administrators, is holding them accountable too. We work with actuaries to make sure that any reductions that a provider gives us gets passed through in the form of lower premiums. And I will tell you that in the Southwest, where our actual fee schedule is not significantly different than Anthem's or United's, and the population we serve is very captive because of our APCD data. We know that there's little out-migration, and yet the difference between our premiums and some of the other carriers using those same fee schedules is as much as 50%. That's accountability and transparency that carries through from the provider side all the way through to the health plan side.
Well, I know for those that were on the Health Summit this morning, that pass through of the savings is a major focus for the administration as well, because so many of the efforts that groups like yours are doing and other efforts as well from a policy perspective, they can make traction in one place, but if that's not passing through and impacting premiums and the out-of-pocket costs for the patient, then there's really, the goals are not being met in that case. So we're not doing this to pad further pockets in between there, but make sure that we've got folks who can afford to get care and providers who are being reimbursed appropriately, and employers who can afford to provide insurance for their employees.
It does mean that you've got folks who are benefiting from the status quo. It's not just providers.
Right, exactly. So we do have a question in the chat box to Claire. So who actually processes the Peak Health Alliance claims, and does PHP have the typical administrative burdens commercial carriers have? So your role is that of a middleman?
So again, I'm going to answer that question on two levels. For the self-funded employers, we allow, they pick their own third-party administrator, and that third-party administrator, TPA, process the claims. So the TPA process the claims for Summit County government, Grand County government, whoever, they use theirs, they load our fee schedules in. That is, and how they structure that relationship with the employer is ultimately up to them. On the insurance side, we are not allowed to bear risk by law. The Colorado statute that enables purchasing alliances to negotiate and do what we do does not allow us to assume risk. So we have to then essentially competitively bid that fee schedule that we've negotiated to an insurance carrier. Right now, our insurance partner is Bright Health Plan, and they process, they function. It's a health plan just like any other health plan. A small group plan is offered, an individual plan is offered. We sell a lot of ICHRAs, but their administrative costs are regulated by the Division of Insurance, et cetera. We do, again, have an actuarial, we take a role of actuarial oversight that we take really seriously to make sure, again, to the earlier comment, that those rate filings truly reflect the reduction that we've negotiated. And we believe we save administrative costs because we have a lot of credibility on the ground. They might say we add administrative costs because we are constantly haranguing them. So it kind of depends on how you look at it.
Bob, did you have anything to add to that?
No, I mean, we are doing it a little differently because we are using a third party, another coalition to do the claims repricing. We're working with the Alliance in Wisconsin. They contract on behalf of some 270 employers and most of the major health plans. So we do use them for the repricing, and then that way we know that the claims are being priced according to the contracts.
Great. Do we have any other questions from the audience today?
I would actually add to what Bob just said. I think that's
Sure.
a really important, an important feature of what, if you can get your self-funded employers to agree to one TPA to ensure that repricing. We do some auditing of our TPAs, and we don't always, I probably, if you audited any TPA, you'd find errors, but to have one relationship with a TPA that really understands how that works is probably, it would be helpful. On the flip side, the CPR study showed that that was often something that made it more difficult to succeed. It is just every purchasing coalition has to find the balance that makes the most sense for themselves and their members.
Great. Well, thank you both for being here and for your commentary. For everyone, just a brief snapshot at what's coming up. On September 16th, we're going to be having another webinar with Sarah Gordon, who is formerly with Brown University and now is Boston University. And she's going to be discussing her experiences using the Colorado APCD data to understand the impact of churn in Medicaid coverage after the ACA. Sarah has been working with our data for several years and is one of our close research partners. So looking forward to hearing how she's been working with the data and sharing what her experience has been. And then for October and beyond, please keep an eye out on civic.org and in our newsletters and data briefs. We will announce upcoming topics and change agents for the Using Healthcare Data to Drive Decisions series. If you have any individuals you would like to see highlighted or any topics you would like to see addressed, please feel free to send those suggestions to info@civic.org. We're always up for hearing where our community is headed and where their focus is. So thank you very much, everyone. I think we're gonna say goodbye a few minutes early. Enjoy the rest of your day and have a great rest of your week. Bye.
Thank you.